as far as the role of echo in mitral clip is concerned, one of the ways is to look at the quantification of mitral regurgitation severity. And the best way to do that would be to go for 2D and 3D proximal isovelocity surface area method, but even preferably using 3D vena contracta. So in terms of the 3D vena contracta, this is, you can do that very easily on the three-dimensional echo. You grab the mitral regurgitation, then you actually come from the top, as you can see here in a minute, and you come all the way down to the area of the vena contracta, which represents the hole in the mitral valve, like right now you can see coming up like that, exactly parallel to the leaflets. Then you enfase it, and as soon as you enfase, one can see the vena contracta. And if you go for PISA method, it assumes the vena contracta to be circular or elliptical, while actually it is, as you can see here, it's always irregular. And so therefore the 3D vena contracta is much better. And you can see the vena contracta, then you can planimeterize it and use the continuous wave Doppler to get the regurgitant volume and regurgitant fraction. Here is using the transesophageal echocardiography, unlike the three-dimensional transthoracic echo which we did before. And again, you can slice it right here and right in this place here, and you can see the vena contracta, and then you can planimeterize it. So that's how we can do it. Now, when it comes to the patients for mitral clip, when it comes to degenerated, which is lower down here, the flail gap should be less than 10 millimeters for best results. The maximum width of the flail clip, a flail segment or should be less than 15 millimeters. Like you can see, that is done best by 3D transesophageal echocardiography. And when it comes to functional, then the coaptation depth should be less than 11 millimeters here. You join the annulus and look at the coaptation depth, and the coaptation length should be 2 millimeters or greater. These actually, if you have these findings on echocardiography, you get the best results here. And the other thing, of course, you look for is also look for leaflet mobility and leaflet calcification. Should be no calcification, or more than 5 millimeters of distal tip should be without calcification. Of course, if the affected segment is central, like you have A2 and P2 pathology, then you have also the very good results here. And just to show one example here of a patient with A2 prolapse, and one can see the cord, ruptured cord very clearly here, and you can see here the prolapsing segment very clearly using this three-dimensional transesophageal echocardiography. These are all the procedure steps. Rather than showing the procedure steps, I think we can go into the, first of all, is the superior and posterior atrial septal puncture should be more than 4 centimeters from the mitral valve annulus for degenerated MR, and 3 to 4 centimeters for functional MR. And then, of course, you advance the sheath and clip delivery into the left atrium. You open the mitral clip arms to verify mitral valve perpendicular element. Then you use 2D-TE long axis view, commissural view, and 3D mitral valve surgical view, close arms. Then you reopen them in the proximal LV, avoiding caudal entanglement. So those are the clues. Now here is just to show the procedure to put the transseptal puncture here. So one can actually make a tent here, so you know where exactly you are going to puncture. And this is on the 2D echo. And one can do the same thing on the three-dimensional echo, because there the atrial septum is like a flat surface, more or less. And you can see where exactly you want to puncture, making sure you are 3 to 4 centimeters away from the mitral annulus. Then, of course, here is the catheter delivery system here. I mean, the delivery system going through the atrial puncture. So I'll just show you quick movies here. So these are can be done very well under echocardiographic guidance. And here you have the images at 150 degrees, 160 degrees, one at 60 degrees with the appendage and without the appendage. And here you have the mitral clip. You can open it just to make sure you are actually advancing it, properly aligning it to the mitral valve. And then this is just to show the color here, in the color. You can see the mitral regurgitation. Then you advance the clip into the proximal LV. And then I think 3D becomes very useful because here you can align, you can see the clip is exactly perpendicular to both the leaflets here. So that 3D becomes, 3D TE becomes very useful. And here, just to again show you another movie here. So here is the clips open, and you are still in the left atrium. Then you go into the left ventricle, and there you can see now the clip has been closed, and you can see there's hardly any mitral regurgitation. Here you can see that we put the color Doppler on, and very little mitral regurgitation is occurring. And you can see that both the mitral valve has been converted into a bileaflet or two orifice leaflet here. And also find that to reduce the amount of radiation in the cath lab, one can use this fusion imaging, where you superimpose the three-dimensional echo image onto the fluoroscopy screen. Here is the TE probe. You put that in, and so that actually you don't have to go back and forth, look at the echo or ask the echocardiographer. You can use the 3D fusion imaging also. And this is just to show an example where the clip has been put in, and there is no motion of the clip here at all. You can see it's quite well positioned in this parasternal long axis view of the mitral valve. Here is another one where the clip is flailed. It has actually caught onto the anterior leaflet, but it's not actually catching the posterior leaflet here. So one can easily diagnose a flailed clip like that, and that can be again repositioned. And this is just to show you mild to moderate mitral regurgitation after placement of the clip. I like to go for mild regurgitation, but mild to moderate is also okay if the regurgitation was very severe. Here is a 3D example of another patient where you had actually a flailed clip where the clip was not properly positioned. And let me just show that to you. Go back here and see if I can run that. And here you can see there are two clips. One is well positioned here, number 2. The other one is flailed, hasn't caught on to the other leaflet here. So just to give you some examples. And here one can see there is a caudal entanglement also. The flailed here is, you can see a little bit of the arrow shows the chordae here. So here the 3D echo becomes very useful when you do this mitral clip procedure here. Well, watch for size of created ASD. If it is close it. If it's large, or there is right to left shunting, because both have poor outcome. You need to watch out for thrombus on guide wire or delivery sheath, very rare. Perforation also, pericardial fusion. So watch all those things. You do a baseline echo and just make sure there's no further pericardial fusion or no further space. Caudal entanglement I mentioned, and then sometimes, very, very rarely, you can have device detachment or partial. So point to remember is, assess mitral regurgitation severity semi-qualitatively, which you do all the time, and quantitatively. Watch blood pressure, very large left atrium, because these will all change the degree of regurgitation. Make sure there are no clefts in the mitral valve or perforation or severe mitral valve annular calcification. Look at the LV and RV size and function, pulmonary hypertension, coexisting AS and tricuspid regurgitation, aortic stenosis. Patients with very mobile mitral valve leaflets, large flail width and gap, may need a second clip, and mitral valve area can be many times reduced by 50% of the first clip and 30 to 40% with the second clip. So these are some of the things to remember. And whatever I showed you here is severe regurgitation, tenting, crossing the atrial septum, putting the clip in the atrium, opening it up and checking, and then in the ventricle, and creating actually a double orifice of the mitral valve. And here's the clip is shown very well. Thank you very much for your kind attention.